So I think right now in ovarian cancer, it's actually a very exciting time. I think I'm more hopeful than I had been previously, because I think we're learning so much more and quickly about not just the tumor, but the tumor microenvironment. When you start looking at tumor infiltrating lymphocytes, Tregs, the expression of PD-L1, homologous recombination deficiency defects. So I think what's really going to happen to an ovarian cancer patient is you're going to walk in, you're going to have a diagnosis of ovarian cancer, and hopefully we'll have some trial available that will allow us to, add an additional agent. But we give carbotaxol to everyone, and most patients, 80% of patients, do really well on that. But how can we improve that, and how can we improve them over the long run? But in the beginning, what we counsel patients is initially you're going to get germline tested. So we germline test everybody. So we know that if you have a BRCA mutation, at some point you will get a PARP inhibitor. But now getting into this space of looking at the tumor itself, I think is really exciting. So, and it's really just been in the last year that started to almost become standard of care, especially with rucaparib being FDA approved, because rucaparib is FDA approved for somatic BRCA mutations. So you have to test the tumor to get it. So that's the first time in ovarian cancer we've ever had anything that was FDA approved based on next-gen sequencing of a tumor. So just making people aware that let's start looking at your tumor and how is that going to direct us, and then putting more and more patients, having more and more combination trials. I think, with the anti-angiogenics, PARP inhibitors, and immunotherapy, those three things, it brings more to the table. It's not just the same 5 drugs that we give every patient with platinum-resistant ovarian cancer that they've always gotten and we've always sort of had. So now we're sort of building our portfolio that we can offer patients, which I think is exciting.